Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking. Welcome, everyone. I'm your host, Todd Searls, Vice President of Business Development, Sales, and Marketing at Caravan Health. And this is Healthcare by the Numbers, a podcast that explores the numbers driving change throughout our industry. To learn more about Caravan Health, this podcast, and to check out episodes of the show, visit caravanhealth.com. And be sure to sign up for our newsletter to be notified of future episodes. You can also visit our program page on Healthcare Now Radio and follow us on Twitter, LinkedIn, and Facebook under our username @Caravan Health. Today, we are pleased to be talking with guests from our client, Alcona Health Center, a nonprofit, federally qualified community health center in Northern Michigan. Susan Hose and Bernie O'Brien will share a healthcare executive and clinical perspective of what they've experienced at Alcona Health Center over these last few years. And we're looking forward to a conversation that will unpackage their strengths, successes, and just how Alcona has been working to improve patient care through ACO participation. So welcome to the podcast, Sue and Bernie.
Thank you.
And my co-host for this episode is my colleague, David Latzer, Regional Vice President here at Caravan Health. David works directly with Alcona Health Center, so I'm very pleased to be joined by him in this discussion today. Welcome aboard, David.
Thanks for having me, Todd.
Well, at Caravan Health, we have been working in rural accountable care since the very beginning. And so I'm particularly excited to hear about what Alcona's been doing to help not only their communities, but their own internal teams through practice transformation and population health management in what we can all know, or what we all know have been very challenging times. So that's why I wanted to begin today by getting to know a lot more actually about our guest roles, the backgrounds, and some of the initiatives that you guys have been doing there. So Sue, I'll let you start.
Sure, thanks. My name is Sue Hose. I am the Chief Finance and Operations Officer here at Alcona Health Center. I have been with the organization for just over 19 years, seeing immense growth in our organization. As you stated, we are a federally qualified health center. We are located in northern Lower Michigan and the eastern Upper Peninsula. We serve a seven county area and approximately 31,000 patients per year. We opened in 1978 in Lincoln, Michigan, which is located in Alcona County, one of the more elderly counties in the state of Michigan. Very rural area that we serve, and just looking forward to sharing some of our experiences through this last year with the group.
Bernie?
I've been a clinical primary care PA for the last 36 years, exclusively with FQHCs. I've been with Alcona now since 1991 and have enjoyed primary care. It's been my niche. We can take care of people, from cradle to grave, and we get older with them, and we deal with, their problems as they come up, and just have a lot of interaction. So, getting into the ACO and doing wellness visits has just been kind of just an outcropping of that.
Fantastic. As one of the founding members of Caravan Health, Alcona has participated with us since 2014, and certainly has found great success and change within the ACO. And that's why I think that they're a perfect guest for today's podcast, because how they've succeeded in transitioning to virtual care, expanding virtual care services, responding to COVID, and successfully implementing population health methodologies. Sue and Bernie, in each of our shows, we like to spotlight and frame our conversation with some of the numbers impacting the industry today. So Todd, do you want to roll with the numbers?
You bet. I think it's fascinating with some of the Michigan numbers we have, plus some of the federal here. In 2019, Michigan had an estimated population of over 9 million, with more than 1 million of those living in rural areas. The state of Michigan, to serve that population, has 36 critical access hospitals and 192 rural health clinics. And during the pandemic, about 4 in 10 adults across the US reported symptoms of anxiety or depressive disorder, which was up from 1 in 10 adults who reported these systems from January to June of 2019. And if we look at a survey for the state of Michigan, it showed that 30% of older adults had ever participated in a telehealth visit by June 2020 and said that a virtual visit was their only option. And among those who had a telehealth visit this past spring, 1/3 had their visits via video connection from the phone. Another third carried out the video visit on a tablet or computer, and 36% had an audio-only visit by phone. In a year-over-year comparison from 2019 to 2020, patients said that they feel very or somewhat comfortable with video conferencing technologies, 64% up from 53% 2019. At least one of their health providers offer telehealth visits, 62% up from 14%. They're interested in using telehealth to connect with a provider they have seen before. So that was 72% up from 58%. And they have concerns about privacy during telehealth visits, but that's going down, 24% down from 49%. So these are kind of overarching numbers from various studies that have been done regarding the implementation of technology and how clients are accessing care, especially during the pandemic. So with these numbers, Sue and Bernie, you're doing the hands-on work every day of improving rural healthcare, implementing population health initiatives in Michigan communities, and basically at its core, just staying connected with your patients. What jumps out to you with these numbers?
I think those numbers make a lot of sense. It was a learning curve for all of us. There's a lot of people that have problems in rural areas with connectivity. So we started up with the Wi-Fi hotspots. I don't think really very many people have issues about the privacy aspect of it. I think that, people recognized it for what it was. It was a time that people had, we had issues about, getting people into the clinics. They were happy not to have to come into the clinics, but yet still be able to be evaluated and for us to care for them. So I think it definitely had its place. As far as using it as, we'll never go back. We'll always have that, as in the toolbox for the future. But I don't think anything really beats the face-to-face visits. And we'll try to do that as long as we can. We can always go back if we need to, as situations dictate.
Right.
Bernie, you mentioned the hotspots. Can you just talk a little bit more about how the hotspot clinic started, how it's, just as you said, how it's sort of impacting you moving forward as well? If you could dive a little deeper into that.
Well, right after the pandemic started, we were wondering how we were going to be able to see our patients, and obviously we could make phone calls and do things like that, but we have a real robust IT team who dove right in and was able to put this together for us, and using tablets and using Wi-Fi connectivity with the clinics. So we had hotspots that were in the parking lots of our various clinics. And again, that being important for a couple of reasons. One is that connectivity can be such a big issue around here. People would have a phone contract that would maybe allow them 5 minutes. So we'd be on a visit with them when they're at their home. And at about 3 minutes, suddenly we started losing them. So it was really, really difficult to get much done. The hotspots were great. People were able to get out of the house. They appreciated it. They were just like, you could see them through the window if you needed to. If we needed to listen to their chest, we could, PPE up and go outside and listen to them if it was necessary. So it was, it's kind of the best of both worlds in that regard.
Mm-hmm.
So there's multiple components there, right? There's the actual expanding the Wi-Fi, that connectivity piece. You had some tablets as well, purchasing those or configuring those appropriately. But I'd like to ask, Bernie, for you to unpack a little bit further than Sue, you as well, the clinical perspective and changing, changing how you deliver care, and you and the other providers, and what that was like. And then Sue, from a leadership perspective, where were your heads? Obviously, there was a lot going on at this point, that a lot of challenges that we were dealing with, but how could you support from a leadership perspective this transition to hotspots, or I guess it was a hybrid approach. Not everyone was utilizing them, but it became a significant portion of your business. So Bernie, you first, and then if you won't mind, Sue.
Well, it was a huge tool. It was, people were scared. We weren't really able to get people in the clinics for the routine care they needed. People that had diabetes that we usually like to see every 3 to 6 months to work on their A1Cs and get their numbers down. They weren't coming in, and so being able to see people, being able to regard their faces, being able to if you've taken care of somebody for a long time, you're able to look at them and know how they're doing. You just kind of get that gestalt. And it was very helpful, much more than just a phone call. Phone calls aren't all bad, but the visual part of this was really a good thing for us. So I think that was valuable. We were able to, the video was really so good. In most cases, we were able to identify rashes and, just some routine things that we might not have been able to do, with anything else. So yeah, it's been helpful. Again, it's not the same as face to face, but during that time, it was pretty darn good.
And then just to take that a little further, like you said, from the other perspectives, organizational level, like Bernie said, the connectivity issues for some of our patients being in a rural area, they may not have good connectivity at their homes or the proper equipment to participate in a telehealth visit. So we designed a model where they could, like Bernie said, come to our clinics and park in designated parking spots that were nice and close to the building. And interestingly, over the years, of course, we have done everything we can to secure our network. And then we were put into a position of needing to have public Wi-Fi. So we developed public Wi-Fi at those clinics where the connectivity wasn't even great for ourselves from the parking lots. But the barriers that we found in doing that, just like anyone else, is the equipment. Trying to purchase equipment to provide these services, and all of the other challenges that came along with COVID, computer tablets, webcams, the microphones. Everybody was looking to get those. And so that was a little bit of a challenge in getting all of the equipment we needed to provide those services. And of course, we wanted to make sure we were compliant in how we were delivering the service, meeting HIPAA, and making sure that they're, like I said, still secure, and making sure that we were able to bill for the services. There are certain licensures of providers that don't recognize that telehealth model. There are some insurances that do not or did not reimburse for telehealth services that over time in the past year did come forward and had relaxed reimbursements. So in the past, as an FQHC, we were not reimbursed by Medicare for telehealth visits, and Medicare opened that up for us to allow us to bill for those and be reimbursed. And so we're hoping that that stays for us. Other than that, yeah.
I think it's, you bring it up, all of these changes had to happen, and then you have challenges in order. You got a great idea. I mean, I used to be an IT director many years ago, and to overcome those challenges in a year is sometimes hard, let alone as fast as you were able to ramp this up. But then on top of that is, chief operating officer, chief financial officer, you're worried about revenue, you're worried about, patient streams, you're worried about your staff. How were you able to connect with all of your different sites, get everybody on the same page, and then, roll out a plan to your community? FQHCs traditionally are very connected with your community stakeholders, be they public health departments or, social workers, social services, things like that. Can you kind of walk through that? Like, when did your day suddenly change? You showed up one day and it was like, wow, forget all of my meetings. This is what we're now focused on.
Yes, we sure did. We're probably middle of March, I think, mid-March of 2020. Like you said, we came into work and our patient visits decreased by 50%. We came together as a leadership group. Our CEO's office became Ground Central, and we all came together from health information, IT, operations, billing, clinical operations, our providers, compliance. We all have something to offer. We all had something to bring to the table to think about when putting this together. It took about 14 days to put 14 sites with telehealth. So, but getting it out into the community, especially in a rural area, we really relied on our Facebook page, our website, word of mouth in the community, working with our local health departments. We really had to get the word out that we were still providing services. We did any marketing tool that we could use, whether it was radio or our local newspapers. It took some time. And like Bernie said, I don't think it was the safety of the visit. I think it was the unknown. I think it was the how do I download Zoom? How do I use my computer to do this? And going back to that parking lot visit, that's where that was so beneficial, with the staff person that came out from the building with the tablet ready to go.
Yeah.
And all they had to do was talk to their provider.
And did you find that there were funds available to help you cover these costs?
We were very concerned at first. Like I said, our world changed overnight. And from the financial perspective, you can't help but worry about how you're going to cover expenses, take care of your employees. But we were fortunate to receive funding from HRSA, Health Resource and Service Administration, and some other local grants, things from even Delta Dental. Michigan Primary Care Association provided some funds. Everybody really stepped up, and we were able to purchase that equipment that we needed and maintain operations while we sorted out our goals and to put those into place.
Yeah, I think Alcona and FQHCs in general have a mentality of pulling themselves up by the bootstraps and scrapping for grant funding and in some unusual places as well. Going forward, right? I mean, we're still obviously the Delta variant is very much in the news these days. Certain different percentages of vaccination throughout the country, throughout the world, of course. But how is your infrastructure, right, beyond the hotspots, looking long term? How has your operational infrastructure been impacted by the pandemic?
Well, I'll take that first, Bernie.
Thank you.
We have found that we needed to add additional staff, screeners at the front door, and people to do testing, outside COVID vaccine initiatives. And with that became space barriers. We increased our staffing, and space became an issue in a time when you're trying to separate staff. But we were very creative and learned a lot. And going forward with that, we're able to create additional space with some of the funding that we received. We're looking ahead, doing very well with our, infrastructure wise, staffing wise. We're in a very, very good place, actually. We have implemented all of those items. We're back to about 90% of the visits that we had pre-COVID. And so we're coming together. We all came together, and we're just doing really well.
So in terms of adding staff, right? A lot of our other clients have been really challenged, in fact, to add staff and have lost more than they've been able to add. And certainly as they've shifted folks to do some of those tasks that you mentioned, whether it's to use door screening or vaccination administration, that they've been pulled away from other activities. It sounds like you've been, maybe I should say, lucky in terms of being able to actually add staff. And, we find, as you know, with the ACO, with team-based care, some of the drivers of that team-based care or the success in the ACO is that team-based care where we leverage out a bunch of different staff. So I guess my question to you with that preamble is, what do you think one of the most important things is for clinical staff to know before joining or being part of an ACO?
I can take that. It's all about the patient. I mean, if somebody is going into medicine and the emphasis of that is to deal, get your hands dirty, roll up your sleeves and do patient care, then that's what you'll be doing with us. And people that have gone into it for that reason, do real well, and we have great relationships and they stay, they maybe go on and develop in other areas and, do some other things with us. But, again, the bottom line with an FQHC is patient care.
Well, I think the innovation that you guys brought to this shows that you guys are a team, right? Everybody got together, everybody decided what needed to be done. And you got to believe that's because you had good processes in place, right? So that you could move forward and do this. But I'm kind of curious, we throw the term hero and things like that out there a lot in our social media campaigns and things. But when we break it down, what you guys are doing is having care for your patients, and you're having conversations with them, and you become their day-to-day heroes when you help them through this. Is there any stories of patient care and or your team doing something that you're just like, wow? I mean, you're just blown away by either the outcome that happened, the response that a patient perhaps had, or one of your team members. You just sat back and suddenly took a whole new appreciation for what they bring to your organization.
I don't know if I could say one thing about that. There's so many, so many small moments and so many wins, throughout the day. And with all of our staff stepped right up and, worked through their nerves and worked through their the unknown. What is all this stuff and what are we going to do? We just keep moving forward. We were able to tell our patients we're still here, and whatever happens, we can contact you. We can talk. We're still around. So, I don't know if there's any one thing. I do know that, our care management program that is, been around and more, we're developing it to a greater extent in the last year. It really started to come on its own, and it's been quite successful in taking care of some of those kind of things, as far as keeping people out of the hospital, and preventing things that shouldn't happen. One of the stories I recall about that is where one of our care managers did her first initial call from somebody who was discharged from the hospital for a stroke. And he was released on what he thought were 4 medications that are essentially anticoagulants. Now, one he'd been taking for years and years and years and was pretty convinced, and it was ingrained that he had to do it. And one of them was new and one of them was a bridge that was just going to be used for a period of time. Well, he was convinced that first of all, his discharge summary said he was only to be taking 3, but he was convinced he was to take the one that he always took for years and years. And I don't know if that was part of his stroke talking or what, but our care manager was pretty concerned about that and said, I just don't feel good about somebody taking 4 anticoagulants. And so she got a hold of the primary care doc. And he said, he said, tell him to quit the oldest one. And she also got a hold of the hospitalist that did the note, and he reviewed it and, said, there was some miscommunication here. So, stop the oldest one and just take the newer one. And that essentially stopped a major bleed in my mind.
Absolutely. And that is exactly the power a care manager can bring, because it is confusing. I mean, especially a stroke, but even just for a hip surgery, right? You replace your hip and you go home, you're on pain meds. As a patient, you're not exactly all there. And conversations you may have had and your wife and or husband and or family members may have heard things differently. So to have someone follow up like that, that's outstanding.
Right. One of the things we have too is we have a lot of senior orphans, and they're out there by themselves. They're living in a rural area and remote area, and they might have some family, but they're kind of far flung, and they don't get out much, and they need a lot of support. So we need to definitely be in tune to them.
Another success story I'd like to share is our behavioral health services to the students in local schools. We have therapists in over 20 schools in our service area. And there was a time when most of those schools were closed. And again, through the telehealth visit, our therapists were still able to connect with those students using the telehealth with the students in their homes. And so not only were they able to continue care for those students in a hard time when they weren't in school and things were different than they had ever seen, but they were able to see the students in their own environment and actually even connect to them more one-on-one, getting a better understanding of who those students are and, understanding their needs. So that was very beneficial, as well as the behavioral health services we provide to our substance use patients who see a counselor at least once a month. We were still able to continue seeing those patients that really, really needed it.
And that's critical programs, right? As students, my son's 11, right? It's not like they're forthcoming with challenges usually. And so to be able to connect with them, but then you're right, the substance abuse, those are regimented programs. And any sort of gap in that, I imagine, would lead to possible adverse outcomes of people slipping or other things. So that's amazing. Matter of fact, that's a great note to myself to follow up on that for another podcast, which is, how telemedicine has really helped deliver care for those. We hear in Nebraska, where I'm based, a lot of vets who come back with PTSD, go back to work on their family farm, and don't have access to care unless it's through telepsych or telebehavioral health. And that's their lifeline. So it's hard to overstate just how important that continuity of care is. Well, Sue and Bernie, it's been a pleasure having you on Healthcare by the Numbers. We are running out of time, so I thought I would give it to both of you. Sue, you first, and then Bernie. Any final thoughts? I mean, again, I am an IT guy. I geeked out reading and hearing about the story of what you were doing by setting up these hotspots, having drive-in clinics. About the only thing people heard of drive-in clinics were COVID swabs, right? A lot less attractive than going in and driving in, getting a tablet and talking about a head cold or something else more serious. So what are your final thoughts, Sue?
Well, just that we've learned an awful lot about ourselves and how we can come together, and we did some great things in a really difficult time. We were able to continue seeing our patients, keeping our employees working, and increasing those telehealth visits from about 1,700 in 2019 up to about 15,000 in 2020. So it's something that we will continue to do to provide those services and just have become a stronger organization working together. Excellent.
Bernie?
Yeah, I think we built up, again, we were there for the community. They supported us, we supported them, and it's a win-win situation. I don't think I can really add anything much above what Sue said. I think that nails it right there.
Well, I tell you, you guys are the living embodiment of the saying that, all those people who are saying it can't be done, just get out of the way and let people who are going to do it, because you did it. So congratulations to you, to your entire team. Thank you for joining us today. For our audience, if you'd like to learn more about Alcona Health Center and their work, you can find them at www.alconahealthcenters.org and LinkedIn at Alcona Health Center. And Alcona is ALCONA. David and I want to thank everyone for listening today. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.